I'm so lucky to get you guys after lunch. Hopefully I'll keep everybody awake. So I'm just here, I'm one of the nurse practitioners for anesthesia. And when I was trying to consider topics for today that I thought would be interesting for you guys, one of the things that myself and my amazing colleagues thought about was just kind of how to help prepare the nurses here in the perioperative area, in the inpatient areas, how to know what to look for when it comes to making sure that the patients are ready for anesthesia. There's so many things that we consider when we evaluate them, and a lot of times we get a lot of questions about what it is that we're looking for. So this is just a way to kind of highlight some pearls that I think will help when considering things about the patient's medical histories and things like that when the patients are scheduled for surgery. So the goals of this talk is to identify patients that require anesthesia in our pre-anesthesia clinics or any type of anesthesia consultations prior to surgery. We'd like for you to be able to perform basic assessments necessary for the patients to undergo safe anesthesia. We want to identify some factors that may delay or even cancel surgical procedures, as well as provide some basic information to educate families prior to surgery. So I wanted to play on something that I know everyone here is pretty familiar with, the ABCs of the BLS PALS training that we go through very frequently. And so in the mnemonic ABCs and the trainings, it allows you to remember the most important things that you consider when you see patients who are having some type of cardiac respiratory distress. So I wanted to play into that with a similar thought process, but then give it a little twist so that it could be applied to the anesthesia readiness. So in this mnemonic, the A will stand for airway, this is in the previous, B for breathing, C for cardiovascular, D for development, and E for education. So I want to start by just introducing our team. My team is awesome, so I had to put in a picture so you guys have probably seen us in somewhere, we're everywhere in the hospital. We see all of the patients before they go under anesthesia for the inpatient side of things. We have a pre-anesthesia clinic here in the outpatient side of things, and then we also see patients prior to diagnostic imaging that requires anesthesia, as well as interventional radiology procedures. And so there's 5 of us, 4 of us are full-time, and then we have a per diem, and then we also have about 24 anesthesiologists. So we're probably the most consistent as far as you seeing the same people over and over again, and so we really try to get to know the nurses on the floor and the pre-op, because oftentimes we're the first resource that you guys may see when it comes to prepping some of these kids. So what we ideally would have is that all of the patients who are going to surgery would be evaluated by a pre-anesthesia nurse practitioner if we could get it to be that way. Of course, because of resources, of course because in some facilities they don't even have the nurse practitioners in this role. What we do here, what I like to do here is kind of give you the resources as well as empower you to be able to do some of what we do in order to prep these patients. So most of the surgical complications that occur are related to 3 categories, either cardiac complications, respiratory complications, or infectious complications. So what we do in the pre-anesthesia clinic is help to try to reduce those morbidities and mortalities by identifying these things beforehand and being able to prepare either the anesthesiologists or even the families and the patients, of course, for lowering the risk of these issues. So the purpose of the pre-anesthesia clinic is to reduce surgical and anesthetic perioperative morbidity and mortality and allow the patient to get back to their normal baseline as soon after surgery as possible. In the clinics, we evaluate the risk and assure optimization of their current state of health, meaning many of the kids have multiple complexities. They have several different organ systems that are having complications. They see specialists from all over the Bay Area many times. And so the goal is to identify the diseases or disorders that directly affect anesthetic care. So oftentimes when we see patients in our clinic, we will identify murmurs that have never been heard before. We identify issues with blood pressure, issues with labs. And so the goal is to identify these before the day of surgery. We also verify disease systems and processes before the surgery. So in the clinics, we're talking to the families about systems and issues that the patients have been facing, who their specialists are, and we're making sure that we're aware, as well as confirming that these issues are at the top of our priority list when we're considering surgery for them. We also like to devise a plan. The NPs, along with the anesthesiologist, will come up with a way to make sure that we're taking the most precautions for these patients prior to surgery so that we can have a plan in place in order to make sure that everything goes as smoothly as we can make it. We do that in the clinic by performing a full, thorough history and physical for the patients. We do this through parent interviews, sometimes patient interviews depending on the age of the patient. We do record reviews before the patient comes. That means if the patient has been to 6 different facilities for surgery or for medical care, we're evaluating those records prior to them actually even stepping foot into our clinic. And so we're doing a lot of prep work before they get here, and most of the work that we do once they're here is confirming the information that we've ascertained. We also do lab reviews, so we're reviewing the results of their most recent labs. We're requiring them to get additional labs if they haven't had any in the last 6 months and their medical conditions have or have not changed. We're also doing consultation referrals. So if I find a murmur or the patient's bradycardic and this is the first time that the family's ever been told, or they are hypertensive in the clinics, we're oftentimes calling cardiology and having the families be evaluated as soon as possible before surgery. For the patients who cannot make it to a pre-anesthesia clinic, which is a lot for various reasons, what I like for you to be able to identify is issues with the ABCDs of these patients. So the A in airway is what we would like for you to do is be able to assess for anatomical or medical conditions that increase their risk of obstruction or airway difficulty during the perioperative period. This may cause the patient to be more susceptible to respiratory depression after some of the meds that they're given. They may be more sensitive to sedatives and opioids and or inhaled anesthetics. These considerations are important because they may change the post-operative care plan of these patients. They may have to stay in the hospital after surgery versus being able to go home the same day. The most easiest way to ascertain this information is to do a review with the family. Has your child ever had what has been considered a difficult airway after anesthesia? Have they ever had any problems with their respiratory system after they've been under general anesthesia for any reason? Oftentimes, we want to know if they've been considered to be a difficult airway, meaning that the physical or the anatomical difficulties that the patient may face have caused them to be hard to intubate at any point, or once they were intubated, they've been hard to extubate. So we want to make sure we have that information. So one way to get it is from the parents. The other is to review anesthesia records from other hospitals. Oftentimes they'll talk about any complications that they face upon intubation, if the patient's laryngospasmed or if they obstructed. They'll also talk about what they did to resolve these issues. So we want to make sure that we're aware of those potential complications, especially if the patient has experienced them before, prior to them undergoing anesthesia here. Things that you can identify in a clinic without looking through all of the records is things that you can look at the patient. Does this patient have a craniofacial abnormality? Have they been diagnosed with something like Treacher Collins or Pierre-Robin syndrome? They have a small mouth or small jaw. Something that could potentially cause an airway complication when they're intubated, or cause a complication after being induced under anesthesia. Does the patient have a cleft palate or a cleft lip? That means that the anatomy of their mouth is not quite the same as the other patients that we put under anesthesia. So these are things that we'd like to be able to identify beforehand so that we can make sure that the anesthesiologist is able to prepare for these patients when they come to surgery. Has this patient ever had a broken jaw? Have they ever had tracheoesophageal fistulas? Things that would make their airways a lot different from yours or mine. We also consider airway tone. Does this patient have an overall hypotonia, decreased tone? Do they have laryngomalacia, or do the parents describe sounds and odd noises when they sleep or when they get excited? These things are important because they can be identified as concerns for obstruction. When we put them to sleep with a mask, do we have to worry about their tongue blocking their airway, or their airways closing in and collapsing because of their history of hypotonia? We also want to identify patients who have been diagnosed or may be diagnosed with obstructive sleep apnea. These patients are more prone to hypoxemia after surgery. They may require more oxygen requirements after surgery. They may not be able to be as extubated as readily after surgery. Even if the parents aren't aware if they've ever been diagnosed per se with OSA, maybe they say, oh, my child snores like a grown-up at night, and when he sleeps, I often have to nudge him or turn him so that he'll breathe regularly. That's important for us to know. If patients have undergone sleep studies, we want to know what the results of those studies were, if any recommendations were made after the studies were done. For instance, was the patient then recommended to be on CPAP or BiPAP, or even were they recommended to take supplemental oxygen at night? Those things are very important for us because anesthesia means that they'll be sleeping. And so if they have those issues during regular sleep, these are problems that they'll likely face after they're put to sleep with anesthesia as well. Also, we want to know about obese patients. Childhood obesity is a huge issue in this country, of course, and because of the likeliness of these patients to have increased oxygen requirements after surgery or complications in general after surgery, we want to know if the patients that you've seen on the floor or the unit are concerned anesthetically because of their weight. Oftentimes these patients have decreased functional residual capacity. It means that their lungs don't take in as much volume because of a heavy chest or because of a decreased oxygen reserve. These kids are often tired quickly when they're talking to you, or they appear to run out of air more quickly. That's important for us to know because that could be an airway issue for us when we put them under anesthesia as well. Also, obese patients tend to have a smaller or shorter neck, which means that they could potentially obstruct when we lie them down and perform induction. They can compress the airway. They could be difficult to intubate, difficult to ventilate as well. So it's also in obese patients and other patients with other types of diagnoses. A decreased range of motion in the neck and mouth is important to identify. A patient who has torticollis or may have cervical instability. For instance, trisomy 21 patients can potentially have cervical instability, or MPS, mucopolysaccharidosis patients, also have the potential for cervical instability. We're doing a lot of maneuvering and manipulating the patients while they're asleep. So if they're unstable in the cervical spinal area, we'd like to know in advance. So for the trisomy 21 and the MPS patients, by the age of 5, we'd like for them to have a cervical film done that allows us to see flexion and extension and make sure that they're not unstable before we put them to sleep. Other areas that may affect the patient's ability to turn their head or open their mouth are abscesses or masses. They may have retropharyngeal masses or submandibular masses. These are all important because, again, compression of the airway is very vital to, knowing about compression of the airway is very vital to making sure that we can safely put these patients to sleep. Also, patients with big tongues. Having a big tongue is a huge concern for some of the patients because it causes obstruction after we get them to sleep with the mask. And so it's good to know we may have to use an oral airway for these kiddos, and we want to make sure that we have all of those things in place and prepared before time. We often ask about reflux. Some of the parents never understand why, but it's very important because a baby who refluxes in any position with or without meals all the time is at a higher risk under anesthesia for aspiration. So we want to make sure that we not only know if the patients are refluxing regularly, but we want to know when does it happen. Does it only happen with food? Does it happen a couple hours later? Does it only happen before sleep? Does it happen if they're sitting up or if they're lying prone? Does it happen if they're eating and drinking, if they only drink solids, if they only drink liquids, or if they're eating solid foods. And a lot of these things are important for us to differentiate the risk with anesthesia. Also, we'd like to know if the patients are on medications for their reflux. Sometimes the patients are on meds, and the meds do help get rid of the reflux symptoms. The parents say that they don't burp as often after eating, or they don't spit up as often. And sometimes the patients are on these medications regularly, and none of the symptoms go away. So that's important for us as well, because we often have the patients take their reflux medications in the morning, but if it doesn't help, it may change the way that we decide to get them to sleep. So the B, breathing. So what we would like to consider in this area is the disease that the patient does the disease that they have affect their, potentially affect their ability to be ventilated before, after, or during anesthesia? Will this patient be a probable concern for pneumonia after surgery, atelectasis, bronchospasms, hypoxemia, or respiratory failure with prolonged ventilation? We want to make sure that we identify these patients early on as well, because as you would know, a parent or a family member will need to know beforehand if there's a potential for the patients to need to stay in the hospital afterwards, if there's a potential for them to have to remain intubated. This is information that not only is good for us, but it's good for the families to prepare themselves. The last thing that most parents want is to be surprised knowing that their kid has experienced some type of respiratory complications that we kind of figured beforehand that they weren't aware of. So one of the questions that we get all the time is around cough and colds and things like that before anesthesia. And I think there's so many different perspectives about what sickness is and how long they've been sick and how sick they are that I think this is a really big topic. And so there are various categories that we identify when patients are coming in after they've been sick. And they're broken down to categories based on a patient's medical history as well as their current history of illness. So the first group of information that I'd like to go over is for patients diagnosed with pneumonia. So usually when we say pneumonia, the parents may come in sometimes and say, oh, well, my baby was sick with a cold and a cough. We went to the doctor's office and they didn't do any x-rays, but they gave him antibiotics and a steroid. Well, more than likely your baby had pneumonia. And so whether the patient say that the chest x-ray was done to confirm it or not, if the patient had to take any type of had any clinical symptoms of pneumonia and was given antibiotics and steroids, more than likely we use that as a diagnosis, and the patient has to then wait 4 to 6 weeks before anesthesia can be done safely. For patients who have a general respiratory infection, upper respiratory infection, with no history of any comorbidities such as asthma or bronchopulmonary dysplasias, and no requirement of antibiotics or steroids, we only make them wait about 7 to 10 days post-resolution of the symptoms. So if they stopped coughing yesterday, we wait 7 to 10 days after their last cough, not 7 to 10 days from the beginning of the cold. For patients who have asthma, their requirements are a little bit different. If they've had any recent exacerbations or they've had a URI that they've required additional medications for, additional breathing treatments, additional physical therapy, chest physiotherapy treatments, or any steroids, those patients also must wait 4 to 6 weeks. Patients who have any type of reactive airway, the reactivity persists for about 3 to 4 weeks after the infection happened. And so we have to make sure that we consider that. And so if a patient is on the unit and they've been admitted in the last week for some unrelated procedure and they were diagnosed with the flu in the last several days, but just because they're not symptomatic clinically anymore, it doesn't mean that they're safe for anesthesia. And so that's one of the big things that we want to make sure that we're informing the teams as well as the nurses who are caring for them. Because oftentimes they'll say, well, they haven't been coughing since they've been here. Yeah, but they were technically diagnosed 3 or 4 days ago, or they've been given medications in the last week for these symptoms. Patients who also have been diagnosed as a baby with bronchopulmonary dysplasia, it's important for us to be aware of that. It means that they likely had apnea of prematurity, they've had prolonged oxygen requirements in the past, and potentially are going to be a high-risk patient for us under anesthesia now at this point. They may require prolonged oxygenation as well, or they may be required to undergo a pulmonary consultation prior to surgery. Patients like patients with cerebral palsy or restrictive airway diseases, we want to know about them because they're at an increased risk of developing complications related to their respiratory system. They experience chest wall stiffness, they have weak muscles or damaged nerves, and these patients often don't respond as readily to the medications that we give them to open the airway or optimize them before surgery. In the preoperative evaluation for them, or even on the floor, we want you guys to tell us if they're not responsive to the bronchodilators, if they're not responsive to the medications that have been given to them to help try to optimize their lungs, or are they currently at their baseline functional capacity? Are they, using the meds regularly and responding to them the way that they normally do, or is something different? If patients are on home oxygen requirements, we want to know as much information about that as possible as well, because oftentimes the families will say, oh, the pulmonologist requires this my son or daughter to take 2 liters at night, but I've only been doing 1, or we only do it on the weekend. And this is important because it may mean that the patient is not optimized. They're not ready for surgery because they haven't been on a consistent regimen that allows us to know that they've been doing what the pulmonologist has recommended and they're responding in an optimal way. Are their saturations the same that they're as the expected saturations that the family has seen in them before? Oftentimes when a patient begins to get sick, we notice because the saturations are lower than normal. They may not have physical symptoms otherwise, but the saturations say a lot about the status of the patient. We also want to know if they're producing more mucus. If the parents say that they suction the patient a lot more than normal, but he's otherwise okay, that's something to consider. On the unit on the floor, if you find that or even in the preoperative area, if you're finding that you're having to do a lot of suctioning or a lot of increased therapies for these patients beforehand, this can be considered a higher risk patient for the surgery that's coming up. And all of these patients will require pulmonary follow-up. All of them need to be cleared by pulmonology, meaning that they need to have, from the pulmonologist standpoint, be able to withstand going under anesthesia, withstand the surgical procedure, and then they also will identify recommendations for the patient to be optimized, what type of medication regimen the patient will need to be on in order to be ready for surgery, as well as what the expectations are after. Will this patient need to stay in the hospital? Is there a potential for them to need to be in the ICU? And they'll also talk to the families, and so having that communication loop, having the families hear it from a pulmonologist standpoint, and then also have them hear it from us, is often more comforting to the parent as they prepare for having their child undergo procedures. The C in our acronym is for cardiovascular. What are some of the factors that may affect the hemodynamic stability for our patients here in the hospital before anesthesia? This may include diseases, medications, and how do we assure that these things are optimized beforehand? The goal is to reduce the risk of perioperative ischemia and subsequent cardiac morbidity. Oftentimes they are easy to identify. They see a cardiologist every 6 months or every 3 months or every 2 months. They have some type of congenital cardiac defect that has been diagnosed either upon birth or was diagnosed later. They see a cardiologist regularly. They're on cardiac medication, or and usually the parents are very familiar with the fact that they have a heart problem. Sometimes these patients have hyper or hypotension that they're followed closely by their primary care doctor for, or they may have bradycardia or tachycardia that was diagnosed without being kind of sought after, but it came up through another procedure that they had, or they went to the primary care doctor for it. And so these patients are patients that we want to highlight when we see them in clinic and make sure that we know for a fact that they are undergoing follow-up for these things. In cardiology, they follow up with those patients and make recommendations prior to surgery as well. They give us clearance based on their expectation for how this patient will withstand surgery as well. And then they give us recommendations about medications. Do we need to do anything additionally for this patient to make sure that they are stable and that we can be as effective in the surgery and as safe in the surgery as possible. This may include EKGs, echoes. They'll let us know if the patient needs SPE prophylaxis before surgery, and if they need to see cardiology even just before the case. Some of these patients need to see the cardiologist, right before surgery to make sure that since the last time they were seen, that they are still remaining stable. Other diagnoses that may affect the patient's hemodynamic stability during surgery in the cardiovascular area are patients that we want to be aware of. If these patients come to the inpatient room and are going to undergo surgery for something, these may be patients that you want to have an anesthesiologist come and consult. Maybe we need to evaluate the patient to see if they've had a recent cardiology evaluation. We may need to have cardiology come and make recommendations for these patients before surgery, which often happens, unfortunately, just before surgery. We want to make sure that safety is key. Also, patients with vascular malformations, AVMs, moya, aneurysms, we want to make sure that neurosurgery is involved, that these patients are stable, that we aren't putting them at an increased risk under anesthesia as well. And then we also want to make sure that we're evaluating patients with any type of endocrine dysfunction. If they have diabetes, Have they had their blood sugars checked regularly? Are they undergoing the recommendations that their endocrinologist made to how they're taking their medications? Have they been following up appropriately? Are they ready for surgery? Have they received a call from the diabetic educators about how to prepare for being NPO, how to prepare for not having food or intake, how do they decrease their insulin regimen prior to surgery? So all of these things are important and that we assess for, and generally we'll make sure that you guys assess for as well if they're on the floor, if they're in the perioperative area, to make sure that they're stable for surgery. Also, do these patients have hypothyroidism or hyperthyroidism? This also affects the potential for complications under anesthesia. It can cause them to be tachycardic, bradycardic. They can undergo a thyroid storm. So we want to make sure that endocrinologist is actively involved in their care, has given them clearance, has made sure that their labs have been stable prior to surgery. We often get calls saying, oh, well, I know this parent is, a great parent and follows my instructions to the T, and oftentimes they don't. And so what we do in clinic is send the kids just before surgery to have some final lab work done, if they haven't had any in the last month or two, to make sure that everything is stable. And then any type of adrenal insufficiency. If a patient has been on any type of steroids for a prolonged period of time, we want to make sure that we know about this as well. We have to give them stress dosing before surgery. So if a patient comes to the unit and we realize that they've been on steroids for any type of dysfunctions, adrenal dysfunctions, we want to make sure that we prepare the surgery so that the cortisol levels are normalized, or at least the stress dosing is given on the day of surgery beforehand, so that we don't have to identify any additional risks because of them being on prolonged steroid use. Many of the patients who come in from the oncology, hematology clinics have great follow-up. They tend to follow up with those clinics very often, but there are those who may not. What we want to make sure with those patients, especially if they are on the units or in the perioperative area, is that the hematologist or oncologist is involved and has made recommendations, that recent labs have been drawn for these patients, and that if there are any contraindications to surgery, that we're aware of them. Many times they require preoperative interventions. Some of them require factors to be administered. Many of you may be familiar with the providers from the hematology clinic, because they come over and they provide IV administration of these factors before surgery. They may require patients to be pre-admitted to get hydration or to get blood transfusions, so that we can make sure that their anemia is controlled and resolved prior to surgery. Or they may just have them come in earlier for any coagulation studies, so that we can make sure that there is no additional risk for anemia or low platelets before surgery as well. This is also inclusive of the oncologic patients who also tend to be pancytopenic all the time. And so we want to know what the guidelines are based on their oncologist's recommendations. In normal patients, hemoglobin may be 10, and we may question, whether or not we should do this, but for an oncology patient, it may be 7. And so we want to make sure that we have those guidelines in place beforehand, and that everyone involved is aware that if the patient is below those, that there needs to be interventions prior to surgery. And then there's always the questions of medications that affect the hemodynamics. Is the patient on anticoagulants? Are they on aspirin? Are they on NSAIDs for pain? Are they on any type of cardiac medications, specifically beta blockers and calcium channel blockers? Or are they on diuretics? And all of these medications have different requirements for what we recommend in regards to preparing for surgery. For patients who are on warfarin, we want them to be transitioned to heparin, which has a shorter half-life and is safer before surgery in order to prevent bleeding. For aspirin, we want the patients to stop the aspirin for at least 7 days prior to surgery in order to lower the risk of bleeding. And with NSAIDs, about 3 to 5, depending on who you ask. With any of the cardiac meds, we generally will consult the cardiology department and talk to them about, some of the patients we can just have them give it the day of, but some of the patients will have hold. Maybe their blood pressures are not that high, or they're not that hypertensive or that tachycardic, and being an NPO for many hours, they run the risk of having the blood pressures too low if they take the medications and don't have food and don't have fluids. And so we have to take all of those things into consideration when we recommend whether or not they give the meds or not. And with diuretics, we generally just will hold them. If the patients haven't been taking any fluids, We don't want them to go 6 additional hours during the day on a diuretic where they're going to the restroom all the time and don't have any replacement fluids for them. And then here we are at the D. The D is more of the development area for our patients is more of the mental health and often addressed with not just the NPs, but with the child life specialists and other folks involved in the care of the patient on the day of surgery. We want to take into consideration any type of mental health or medical conditions that should be considered and can affect the patient's ability to be ready or be prepared for surgery in the social aspect as well as in the medical aspect. Does this patient have seizures? Are the seizures well controlled? Are they on medications for these seizures? Have they had any recent changes in the frequency or the presentation? Has the family been concerned about whether or not this patient is fully controlled or is having side effects of the medications? And we want to make sure that they're following up with their neurologist regularly before surgery. Anesthesia does reduce the seizure threshold for many of these patients, and so we want to make sure that we know about any concerns that the family has about the status of their seizures. For patients with developmental delay and autism, you guys will have an autism talk next, so I won't go deep into that, but it's definitely something that has to be considered. If they're on the unit and they're going to be undergoing a procedure, how do you communicate with those patients? What learning level are they at when they need to understand what's going to be happening to them and how it's going to be progressing? We like to get child life involved, but sometimes they're not available. So how do we help to prepare the patients for this procedure in a way that's conducive to making sure that they're safe, as well as making sure that they're not traumatized by this experience? We often talk to the families, we talk to the caregivers, just so that we can know, how do they cope in a busy environment socially? How do they deal? How do we distract them? How do we make sure that there's no previous trauma from the last time they were here? And if there was, how do we avoid that this time? Do we take them into a quieter room? Do we have them with their favorite toy? Do we allow the parents into the induction room? All of these things are very important in understanding the development of that child, regardless of age, but more of understanding their development and identifying ways to make this experience better for them. Also, mental health diagnoses such as anxiety and depression have to be considered. Many of our patients come in and they have anxieties from other traumas that are unrelated to surgery or just have general anxiety. How do we make sure that we give them what they need in order to successfully go through this procedure, and that if they have to return to the hospital later, they're not having some past trauma brought into the next one. So for some of those patients, we use the same thing, distractions. We may use guided imagery or meditation depending on the age. We have the child life specialist again consulted because we want to make sure that they're involved in making a plan for those patients on the day of. Ideally, having a plan before the day of surgery is the most beneficial. Sometimes those families will go to their primary care provider to get Ativan or some type of relaxant to give the patients even before they leave the house. So if that's the case, if that's what the patients require, we want to make sure that that's considered early on. Some of the patients are fine until they get here to the hospital. With all of the noise and all of the providers, they need some type of relaxant once they're here. So we use pre-medications, usually a benzodiazepine, so Versed or Valium, to help relax them. It helps to calm them if the families aren't able to be there during the induction, depending on where it is. It helps to allow the nurses to do their job, to get vital signs, and even just gives the family comfort in knowing that they don't have a child who is so anxious and so worried about the procedures that they can't even focus on all of the other things that they have to do the day of surgery. These meds can be given PO, these meds can be given intranasally, and they can also be given IV depending on the patient. And then education. These are just the basics for preparing patients and families for surgery. We often assume that the patients who are inpatient don't have concerns about the NPO status, but that's usually where they have the most questions. We've even had, nurses there who weren't sure because these change a lot. We've had multiple changes to our NPO guidelines in the last several years, and so just going over that today, I wanted to make sure that everyone was on the same page. And so the basic instructions are that solid food or any milk or nutritional supplements have to be stopped at least 8 hours prior to surgery. For all of our outpatients, we generally just tell them to stop them at midnight. It's easier for the family, it's easier for us if we get some openings earlier in the morning or the day, and it helps to kind of keep everything streamlined. For formula, which usually is like a powder-based formula for our infants, like an Enfamil and things of that nature, we stop at 6 hours prior to surgery. Breast milk can be given up until 4 hours prior to surgery, and clears, surgical clears, not necessarily general clears, which on the floor includes like Jell-O and Gatorade and all of that. We like to kind of eliminate all those options and identify surgical clears as clear apple juice without any pulp, water, Pedialyte, or Sprite that they can give up until 2 hours before surgery. One thing to consider also is that a lot of our patients have trouble swallowing or are unable to swallow thin liquids independently of thickeners. So if a patient is on a thickener, please take that into consideration because they no longer fall into the 2-hour guideline for clears, and that needs to be discussed further prior to giving them NPO instructions. Also, making sure that the patients are receiving medications that are integral before surgery is another big question that we get even from within the hospital. The patients may be scheduled to have their reflux medication disease can cause on the procedure. Meds that we'd like for them to hold are usually diuretics, anticoagulants, metformin, things that stay in the system for many hours before surgery, and that may be affected by their inability to eat or drink. And then on the day of surgery, we want to make sure that the families are aware of who they'll be seeing and what will be happening. They'll be hopefully seeing a child life specialist. We want to make sure that consents have been done because those have been known to hinder the surgical process as well, if not cancel, depending on if the families are not familiar with the fact that a consenting adult has to be here on the day of surgery or available by phone to consent for the surgery. We also want to give them an understanding of what the length of the surgery will be, whether they'll be expected to stay after the surgery overnight, medications they'll need to take, and any equipment that they need to bring. Families are usually not aware that they have to bring in a CPAP or BiPAP if the patient is on one at home, and it has to be assessed by engineering, which means that instead of the hour before surgery that they needed to be here, they may need to be here an hour and a half or 2 before surgery. So those things and those expectations should be identified beforehand. And then the most important thing, if a patient gets sick before surgery, we'd like for the families to be aware of who to talk to, because oftentimes they come here and the families are not aware of who they should consult or discuss illness with, and then they expose patients who are also going to surgery to their coughs or their runny noses or their potential flus, and they bring in family members who are sick as well. And so the goal would be to identify this before they arrive, give the family the benefit of not having to come in with a baby NPO and then be canceled, and then also not expose the patients who are already here to these diseases and illnesses. So having them have that contact information is ideal, whether it's in the outpatient setting, or even if the patient is supposed to be scheduled for a surgery that they be pre-admitted for inpatient. We want to make sure that they know that if a cough or runny nose or vomiting or any of those things come up, then we want to make sure we be considerate of their time by not making them come and having them consult someone over the phone first. And that is it. I think with those that are undergoing anesthesia pretty readily, and make sure that they save you all and us all a lot of time, and the families a lot of heartache by having their patients canceled at the last minute.